Anisha, like I don't wanna.
So here's the thing. Here's that we are recording right now. Okay. Okay. So you have a 39-year-old white male who present with a 2-day history of increasing fever and chill. Okay. Let's see. Uh, so look at the vitals. Fever is 103. Heart rate is 112. Blood pressure is 112/70. Respiration is 12 per minute. Okay.
Mm-hmm.
He complained of anorexia, diffuse joint pain, back pain. He also has some myalgia and has noted several painful spots on his fingers. He denies chest pain, shortness of breath. Wow. So you get some idea what's going on, right?
He denies what?
So he has several painful spots on his fingers. He's anorexia, diffuse joint pain, back pain, fever. I'll give you more information. He's positive for IV drug abuse. He has some personality disorder, tobacco use, alcohol use. So you gotta counsel him on that. He smokes 2 pack for every day. That's you gotta counsel him on that. Drinks alcohol every day. Admits using IV drug abuse. So you gotta counsel on all of that. He was tested for HIV and hepatitis C recently for pre-employment. That was negative.
I cannot hear you clearly. Sorry.
He was tested for HIV and was negative.
Uh-huh.
Okay. So now, how do you approach this case? This is a very
Okay.
interesting
This
case.
is a infective endocarditis.
Yeah, excellent. It is an infective enteritis. So this is like, whenever we read the case, we gotta put on our mind what to counsel and what to screen. So we
Yeah.
gotta counsel him about those 3 things: social
Smoke,
history.
alcohol, and drugs. Yeah.
Yeah. And then, what else do you want to do? Do you want to do any screening on him or something? Like, just to keep in mind, he's 39. Maybe lipid profile. I don't know. We'll see what there is. What do you do? Do you want to do any other screening on him?
No, he's fairly young.
Yeah.
We already did the HIV test on him, so he was negative.
Okay.
So let's take he came to the ED. Let's
Okay.
do a quick physical.
Excellent. Yeah. So this is good. Yeah. So what do you want to do? Okay.
Heart, abdomen, maybe extremities, because he said his fingers were something was wrong.
Okay. Something really quick. So he's appearing white male. Oropharynx is fine. Pupil are round equal. Conjunctiva shows small hemorrhage. Neck, there is no abnormality. Cardiovascular tachycardia and hollow systolic murmur in the left lower sternal border, increase by inspiration, decrease by expiration. Okay, do you hear me?
Yeah, increase.
Yeah. There's needle marks on the arms and splinter hemorrhage, 2 palpable painful villaceous nodules on the digit of the right hand. Okay? You got what's going on? Okay, that's
Yes.
now. So what do you want to do now?
So first thing I'm going to do is start him on IV access.
Yeah, let's
Give
do
him
the police. Okay, pulse, oxygen, police, all intubation or IV access. Okay, C. Okay, what else? What else do you want to do?
I wanted to give him IV fluids, Tylenol.
IV fluid, yeah, Tylenol.
Um, that's okay. I
Let's
mean,
do
we can
CBC, CMP. That's what they're getting.
BC, CMP, chest X-ray.
And then infection protocol. Okay, blood culture, chest X-ray. What else?
So I want to do UA,
Urinalysis, yeah.
TSH, urine
Culture,
tox, urine
urine
culture.
toxicology, yeah. What else?
TSH, lipid profile, ESR. You did EKG already.
Yeah.
Magnesium. Check his magnesium.
Magnesium. That's the M glim with the cut glim, is that?
Yes, magnesium and phosphorus. You can check on everybody.
No, yeah.
And then, do we need to do sputum culture on him?
He doesn't have cough or anything like that, so there's no need for
Oh,
it.
oh,
And we do PT. Let's do PT stuff. Alright, okay,
what's that? Why?
huh?
Why?
Just in case that he's having hemorrhage
Okay.
or abnormal coagulation, because you know it's an infection, can have DIC and stuff.
Yes.
Horrible. Mhm. Okay,
Now I'm gonna start him on antibiotics too.
good job, yeah. What
Um,
antibiotics do you want to say?
vancomycin.
Okay, what else?
Mm, I don't know. I don't know antibiotics. Oh, what
uh,
else? What else do you? Okay, tell me the bug, and maybe I'll tell you the antibiotics. What
we can
coverage?
give him gentamicin or ceftriaxone also. So you know, you
Uh,
wanna, now we don't know what the bug, right? So he's IV drug abuser, could be Staph aureus, could be. So we want to cover something gram positive and gram negative. So we just want to shoot blindly. So we give him
hmm.
Vanco for positive, Gento for negative. And
And ceftriaxone is also for negative, right?
yeah, ceftriaxone for negative too. Yeah, you can give him ceftriaxone too. Hmm.
You didn't spell it right.
Yeah.
Genta. Mm-hmm.
Okay, now
I'm gonna
it's the
move him
time
into
to admit
inpatient.
him. Yeah, right.
Admit him. And then there is a mnemonic for admit also.
Yeah.
It's hat. I forgot.
What is it? Hmm?
I forgot. What was the
Uh,
name of the
v panic.
panic? So P for um PT. I forgot.
V for vitals. V panic. Panic. A
A
activity.
for
Bed
act.
rest.
I remember A for activity.
Panic. N for NPO. Uh, panic. Yeah,
For
or NG tube. I
NG
input output.
input output.
Pneumatic compression. PTT, I think. PTT dot P, right?
Maybe it may be.
Yeah, so
I
that's.
forgot. Just did it yesterday.
Yeah, these mnemonics, that's the thing.
And then you have. Okay, good.
Okay, now let's just check him out. Let's just advance the clock for a few hours to see. Okay, so the labs, you have oxygen saturation is 97%. You have
Mm,
18,000 CBC white blood cells, okay?
mm,
Hematocrit is 35, hemoglobin 12. X-ray
mm,
shows two very small wedge-shaped infarct with cavitation. So now it's a good clue for Staph aureus. So we got to order the vancomycin. Electrolyte normal. BU1 is fine. PTT is normal. Sinus tachycardia. Toxicology is positive for opioid.
mm.
Okay.
For opioid.
Yeah.
So what do? We give him thiamine, naloxone, or is it they're just saying that he's using it?
No, it's just positive, but he doesn't exhibit like opioid symptoms. So now let's just take care of the infection for now.
Okay.
It's not acute something acute opioid. So let's get what is the gold standard for diagnosing infective endocarditis. Let's stabilize him. So that's the first thing. You stabilize him. We advance it for 8 hours. And then what do you want to order right now?
Blood cultures again? Oh no, we didn't even get the first one yet, right?
Yeah. So let's see him next day. So by next day, his fever a little bit down. He's more cooperative and stuff like that. So we can do something. What is the gold standard for an infective endocarditis?
Echo?
Yeah, TEE. We can do CBC another time. Okay, and what else? Let's test him for hepatitis B. But he was tested for hepatitis B and C and HIV. If he was not tested, then we would have ordered that, okay?
Yeah.
Transesophageal echo
Mm-hmm.
and CBC. I don't know. Yeah, esophageal, transesophageal. Good. Yeah, yeah. So you just need to order TEE. You don't need to write the whole thing.
So TEE, you do it after he stabilizes?
Yeah, and consult infection.
Hmm?
You can consult infection.
Yeah.
A school infection, like the only thing you have instantaneous results.
Mm-hmm.
Okay, so now so you got the blood culture shows Staph aureus and methicillin sensitive in 4 out of 4 bottles. Okay,
Mm-hmm.
TEE shows vegetation.
Mm-hmm.
Okay, so let's see him next day.
So are we gonna change our antibiotics?
Obviously, yeah.
What are we gonna change it
You
to?
lose points if you don't.
So he's methicillin sensitive?
Yeah, so first we discontinue vancomycin. And then what do you order? They love this thing. You have to do that. What is it? Methicillin sensitive. What do you order?
Oh, nafcillin.
Yeah, you did methicillin. Okay. So how long do you give antibiotic for these types of people like who have?
I think I'll give it for 3 weeks.
Yeah. So what do you need for that? We need central line, right?
Yeah. Pick line.
Yeah. Let's put central line placement. You know, from sitting for the whole day, my back hurts. Damn.
Me too.
Yeah, like I feel like an old guy. You know, damn.
Hmm?
And
My
then,
back hurts too so much.
yeah,
I have to get up and stretch every hour.
yeah, yeah. But and then blood culture. What else? What do you want to do? Let's
Um,
repeat the culture. Central line insertion. Let's just monitor him. That's what we can do. Let's see him next day. That's
but
it.
we cannot discharge him on central line. He cannot be in the hospital on central line for 3 weeks. Why didn't you put a pick line?
Yeah, we can do that too. But in the U word they say central line. Yeah. So now what do you want to do?
I want to counsel him now.
Let's see him. Let's continue. Keep checking on him until he gets better, much better.
Hmm.
On the 5th day, we'll counsel him. Yeah, let's counsel him now. Yeah, now he needs a
No,
lot of counseling.
there's a lot of counseling.
So let's see alcohol use. You want to counsel him breast self exam? No, I'm checking. So you know, breast self exam is not effective at all. I don't know why they keep it in the software.
Breast self-exam?
Yeah,
No.
yeah, it doesn't.
Mm-mm.
Yeah, it's not like it's not helpful at all. It doesn't detect cancer. It shows a lot of false positive.
Right.
Legal. Let's see what else.
They don't recommend it.
Yeah, yeah. So what else? What do you want to do? Rest at home. Safe sex technique. Do you want anything else?
Mm, safe sex, seatbelt, educate, compliance with medication. That's it.
Let's see. What is?
Vaccine. Give him pneumococcal and influenza.
Yeah, exercise. Let's give him exercise and stuff. Oh, this is important. Subacute bacterial endocarditis prophylaxis. That's a big one
Hmm.
because he's gonna need a prophylaxis. Okay, now you want to discontinue anything? Let's discontinue NPR. Discontinue bed rest. Let's remove that. Remove that. What is it? Is there anything else you want to do? Vital signs. Remove it. That's assuming that he gets better. It's better.
Hmm.
Okay, now let's just send him home. And let's follow up with him on next week.
This was not bad. It was an easy case.
Yeah, yeah. It's a good case. But they can play it in many different ways. So this how do you summarize this case?
So, any male with history of IV drug user and high fever, um, and a murmur, definitely, on physical exam, is infective endocarditis. So, our job is to first make sure we get cultures, we stabilize him, bring his fever down, um, and start treating him empirically. Once that's done, with especially broad spectrum, Vanco for to cover gram positive and gentamicin or ceftriaxone to cover gram negative, and then we admit him. And once we admit him, we follow, and once we get the cultures back and we see what the sensitivity and to antibiotics is, we change accordingly. Once we change that and the patient is stabilized, fever is down, we do a TEE to confirm any vegetations or valvular, you know. So once that comes back, since we know this patient is endocarditis, we have to give him long-term antibiotics. We change his regimen to his central line, so make sure he's getting his medication, and we discharge him after a few days, um, with the precautions and prophylaxis and counseling.
So what are the major and minor criteria for infective endocarditis? Mhm.
Major and minor. Hmm. Oh, isn't this the Jones criteria? No, not Jones. This is from
Jones called
Jane.
rheumatic fever. This is called Duke's script.
This is from Jane,
Yeah.
right?
No, they call it Duke's criteria.
Oh, I'm sorry. This is like, can you tell me about it? I don't know. Fever.
So I'm gonna tell you
F
the major and you tell me the minor. Major positive blood culture and positive echo. How about the minors? What do you think?
Major is positive blood culture and what?
Positive echo, transesophageal echo.
Oh, Minor would just be like fever, rot spots, osler nodes, right?
Yeah, right. So if the patient you have suspicious of major complication, like you have headache and stuff, what do you do with infective endocarditis? What do you do?
Oh,
Or abdominal pain? What do you do? If infective endocarditis with headache, infective endocarditis with abdominal pain, what do you do?
infective endocarditis is it goes like to every organ and it causes problem. So it can cause like strep bovis can cause colon cancer, or it can go up to the brain and cause encephalopathy. I'm not sure. I don't know where I'm going with this.
So it can cause septic emboli, like septic can go to the brain, so it cause stroke. So they have headache and neurological
Oh,
weakness.
it can cause a PE. It can go to the lung too.
Yeah, it goes even to the abdomen,
Or
cause mesenteric ischemia. So how do
oh,
we diagnose that? Then in this case, we order CT.
CT. Yeah. Oh, this is how you're saying they can twist it. Okay.
Okay, yeah.
Okay.
How about if the patient is intolerant to nafcillin, develop a rash or something? What do you order?
Hmm. You change it.
Medicine is like infinite. There's so many things that you can play around.
Yeah. I guess you change it to the next class. I don't know.
You change it to cefazolin.
Cefazolin. But that doesn't cover gram positive.
No, it does cover.
Oh, it does?
Yeah, it covers the methicillin sensitive
Okay.
stuff like that. So when should you obtain cardiovascular surgeon consult?
When the TEE is positive.
Yeah, if you have unstable prostatic valve endocarditis with staph aureus or staph epidermidis, or relapse of prostatic valve endocarditis after antimicrobial, and large hypermobile vegetation can cause septic embolization. Okay, so
Mhm.
that's when you have complication of that, you order cardiothoracic surgical consult.
What do you order?
You order cardiovascular surgeon
Mm-hmm.
consult. Okay.
Mm-hmm.
Okay, so that's it. So for anyone who have infection, there is infection protocol, which is urinalysis, chest X-ray, and all of these sort of things.
Mm-hmm.
Okay, so if emboli to the kidney, what can cause?
Oh. Mm, renal artery. Actually, I don't know. Ischemia.
Can cause focal glomerulonephritis, and can
Mm-hmm.
cause hematuria. That's why they have hematuria.
Oh.
Can cause heart block, pericarditis, myocarditis, myocardial abscess. It's crazy. You see how the body's so connected?
Hmm.
It's very interesting.
So
Okay.
what
Huh?
about endocarditis can also the strep bovis can cause and strep viridans and then and then there's enterococcus that can cause UTI. Do you
Yeah,
remember?
exactly. Yeah. So if they tell you patient who underwent cystoscopy
Mm.
and then developed endocarditis,
Mm.
then in this case you think of a staph epidermidis. Okay. When you have a enterococci,
Mm-hmm.
cystoscopy.
Mm-hmm.
But when you have a prosthetic joint and then infective endocarditis, then staph epidermidis.
Staph epidermidis.
If you have IV drug abuser, then staph aureus. Okay, what else? Let me remember.
If you get colonoscopy.
Colonoscopy, strep bovis, yeah. Oh, the dental thing, strep viridan,
Viridans.
yeah. What else? What else? What else? Yeah, I think that's we covered the most important ones. Yeah. Yes,
Yeah.
I think that's about it. Okay, ready for the next one?
Yes, sir.
Okay, let's go. Okay, so you got this 60-year-old female with history of coronary artery disease and cabbage, okay? She presented
Mm-hmm.
with dizziness, lightheadedness, and palpitation. Let's check her vitals. Her vitals: heart rate 130, irregular pulse.
Mm.
Everything else is fine. Blood pressure 130 over 75, everything is fine. So now let me give you. She described her palpitation as irregular and almost continuous. She denies chest pain, angina, SOP, or syncope. She also felt a little warm since one day. She denies cough, upper respiratory tract symptoms, dysuria, abdominal pain, leg swelling. Her review of system is positive for frequency of urination. She had history of cabbage, you know that. She has history of diabetes, hypercholesterolemia, osteoarthritis, COPD, gout, you name it. All medical conditions. She has
She
almost
has
all of.
diabetes already?
Yeah, she has everything. Like
Okay.
whatever you want, yeah. Like Davidson, like this big book of medicine.
Mm.
Have you heard of it? Huh?
She has that?
Yeah, she has all.
Yeah.
Yeah. Social history: she quit smoking after cabbage.
Hmm.
Father died of age of 70, and my mom died of age 68 from stroke. Not significant. She's taking, you name it, everything. Like Lippincott of pharmacology, she takes everything. She takes aspirin, simvastatin, lisinopril, nitroglycerin, glypiride, metformin, albuterol, acetaminophen, codeine for osteoarthritis. Boom. She's at the office right now. So how do you approach? So this basically, in a summary, it's atrial fibrillation in office. What is it?
So I'm gonna do a full physical on this lady. She has too much going on. I don't want to miss anything. Do everything on her.
Okay.
And she is 60, right? So I'm gonna counsel her. What did you say? Did she smoke or drink?
She quit smoking and she doesn't drink.
Good. So if she's 60, I'm gonna do a mammo
Yeah.
colonoscopy.
Yeah, we keep it in the end. So there are few rails and decreased breath sound on the left lower quadrant. That's in an exam. Everything else is JVD distension noted. Everything else is negative. So what do you do right now?
JVT and RALs on the left lung.
Yeah.
And she came in with palpitation, dizziness, and lightheadedness with irregular breathing.
Yeah. Let's send her to the emergency room. What do you think?
I wouldn't send her to emergency room. Why? She's stable.
She's atrial fibrillation.
Yes.
She's asymptomatic. Her heart
Oh,
rate
yeah.
is rapid.
Okay, send her. Yeah, you're
Yeah.
right.
And
I knew she had AFib.
she has
I
so
thought,
many things going on already, and and these people are 60 years old, like you don't want to mess around too much with them. I
oh,
remember one time one of my relatives, he was like 40 years old.
hmm,
He's a young guy, but only because he's a little bit obese. Obesity is a risk factor for atrial fibrillation.
mm-hmm.
So he had atrial fibrillation,
Oh,
and they sent him to the emergency room, but he only had to stay in the emergency room. He didn't go had to go anywhere else. Interesting.
hmm.
Medicine is interesting. Okay, so now let's just do pulse ox, IV access, and EKG.
What about the police?
Yeah, let's do the police. Yeah, police or oxygen. Yeah, those are the same
What
thing.
the what is L in police? I keep forgetting.
Lung intubation if unstable, if the lungs have no.
Oh,
Police.
what was C?
Uh, Let me. Like, I don't know what. Okay, so P, pulse, O, oxygen, Al, division, I, police, EKG, C, CMP, I think. Let me check it out right here. 1 second. It's right there.
It's okay, don't worry. Let's just do the.
Okay, so it is, yeah. The C is for sugar, figures the glucose.
I was gonna do that anyway. Okay,
No,
let's go.
cardiac
Let's
monitor, cardiac monitor.
cardiac monitor. There you go. BP monitor.
Yeah, BP monitor.
Okay, now let's do the
And
CBC.
finger stick glucose. Undo CBC, CMP.
Do CMP on the next line.
Yeah. I wonder if it's if it's in the same one. Let's see. I'll try now.
Okay, do a chest X-ray.
Yeah. What else?
Urine analysis.
Lipid, urinalysis, and TSH. What else?
TSH, ESR, EKG. You did already.
Magnesium. You said.
Magnesium and phosphorus. I think that should cover most of our bases. I definitely need her EKG like stat.
Yeah, I'm gonna do most of them. Style. Okay. Let's get some of the results.
So what are the results?
94% are oxygen. EKG shows atrial fibrillation with rapid ventricular response. And there's a Q wave in the anterior lead consistent with all the MI.
Hmm.
Left ventricular hypertrophy pattern is noted.
So no AFib?
No, there is a fib.
Okay.
Yeah, plus all the MI.
Okay.
So now let's not delay the. Now, once we get the EKG, let's
I
start
want to
the.
give beta blocker. Give her beta blocker. We have to do rate control
She's
first.
having heart failure.
She's having what?
Heart failure.
She's having a heart failure?
Yeah, so we don't want to give. And she's COPD, heart failure. So you
I
gotta
didn't
be.
know she was COPD.
Yeah, because I said them like maybe said them quick and stuff. Yeah, she has COPD. Now I'm telling you.
No, then no beta
So
blocker.
what do you want to do?
She's having a heart failure? How do you know she's having a heart failure?
She had a cabbage, hypertension, like all of these kind of stuff, and there's JVD noted too. So maybe a little bit heart, even if not heart. Oh, even if not heart failure. Sorry. The COPD beta blockers contraindicated. So what do you want to do? Give her the cardiazem. Okay.
Okay. What's that?
This
Cardiism.
LFT, huh? Verapamil and diltiazem. This is diltiazem. Okay, let's do
Okay.
T4,
Do
PTT,
you want
T2.
to
Hmm? What is it?
um do you want to, if you think she's having a heart failure, do you want to order BNP and cardiac enzymes?
Yeah, let's do that. Yeah, that's a good thought. Yeah, I like that. Yeah, that's a. It's not an exacerbation. I think it's pretty controlled. That's what I think.
Hmm. She said she doesn't have chest pain.
Yeah, she doesn't. It's not, yeah.
She said she's feeling warm and she's feeling like I thought she's having first I thought she was hyperthyroidism. Then I'm like, AFib is associated with hyperthyroidism.
Yeah, exactly. But AFib, it's not with just hyperthyroidism. As AFib caused by obesity, can be caused by diabetes, can be caused
Mm,
by hypertension, can be caused by mitral regurg, heart
yeah,
failure.
yeah.
So many causes. Like I was looking at them today.
Mm-hmm.
So many causes. Like it's huge. So now let's just admit her. Now V panic. Okay, V vitals. So panic Prozac and Prazole if you need anything. PPI. So we don't
Mm-hmm.
need that here. How about diet?
Active
You want to put her normal diet?
normal diet, bed rest with bathroom,
Okay. What else?
PTT.
Input, output, PPT. That's it. Activity. Give her bed rest and stuff.
You didn't give me results for anything.
The only abnormal one is that the EKG. Everything else is fine. EKG shows
Oh,
atrial fibrillation.
what about BNP and proponents?
So I just admitted her right after I ordered them. So let's advance it and we'll see what's. No, we admitted her. Oh, let's put her on telemetry. Just a second. We could put her vitals on pulse ox every 4 hours.
Mm-hmm.
BNP is fine. Cardiac enzyme is fine. Sorry. Now let's check her glucose because she's diabetic.
Hmm.
HbA1c. What else? What do you want to do? Let's do echo check. Echo. Okay.
Mm-hmm.
I like this case is very interesting. There's a lot of stuff to it, and we do echo check every 4 hours.
What's echo check? Blood glucose?
Uh, or every 8 hours, doesn't matter. You want to continue the same home medication, lisinopril, simvastatin. She's taking heart failure on MI regimen. We
Yeah,
continue
why
the
not?
same, okay? And we put her in. So we gave her diltiazem. Do you want to give her anything else?
Can we give her
Something, she's at her AFib. She's at risk of what?
warfarin? Warfarin.
No, heparin before that.
Oh, heparin.
Okay, and then warfarin. Put her on heparin. And by the way, we order FOBT before heparin.
Why did we wait 3 hours before we give her heparin?
Hmm?
Why we gave her heparin after 3 hours? Shouldn't that have been the first thing after EKG?
Yeah, it should have been in the beginning, yeah. Heparin. Yeah, you're right. Yeah, it should have been in the beginning. Like in the explanation, they said like they ordered it right after like some time. But yeah, it should be in the beginning. I agree with you. We do.
Mm,
And then we do PTT every 2 hours, every four
mm-hmm.
hours or so. Yeah.
Yep. Um. Okay.
Let's do it every 6 hours, not too much. Okay. And CBC, let's put it daily. Okay. So now let's check the results of whatever we ordered. So CBC is around 12,000. BMP-NA is 140, K is 4, so it's okay. The chest X-ray small, left pleural effusion. Okay, urinalysis shows positive esterase. 50 white BC, many bacteria. Okay, PTT is 30. First set of cardiac enzyme negative. Echo shows normal left ventricular function. Ejection fraction is 50. Mildly dilated left atrium. Mild hypokinesia of the anterior wall. So those are the results so far. So what do you want to do right now? What is she having? What should you do right now?
Is she? Wait, what is
So
she? I'm so
I
sorry.
like this case. I like this case. It's atrial fibrillation. Your analysis is positive now. What do you want to do?
Urinalysis positive for what?
Leukocyte esterase.
So I'm gonna give her TMP-SMX.
Give her Bactrim, yeah, TMP-SMX. Do urine culture and sensitivity.
Oh. Okay.
Bactrim saying TMP-SMX. Yes, we can give it oral. It's okay. Urine culture.
Oh, because she's diabetic, so she's prone to UTIs.
Yeah, let's examine her after 2 hours. Now let's see how she's doing now. Just check her heart. Yeah. She hopes the medication will help her with this stuff. So what do you want to do right now? Now we just let's check her out in like a couple of hours too. Like in 4 hours, let's see.
That sounds good.
See how's she doing. Yeah, she helps the medication help her, you know. You know the vitals that we ordered every 4 hours? Where is it? I don't know why it's not showing. It's every 8 hours. Okay, let's see where's the next vitals. It should be every 4 hours. Order vitals one more time. Every 4 hours, you know. So we're monitoring her till the heart rate calmed down. Oh, what happened? Stupid. Vitals. Why I don't know.
Okay.
Okay, so let's check her vitals. Okay, so her heart rate is now 67, less than 80, so that's okay. So now what do you want to do? Do you want to keep cardiasm or not? Discontinue cardiasm. Okay, we don't need it. What else? We discontinue the
Now,
IV cardiasm and we give her what? Oral cardiasm.
so diltiazem is so you can give verapamil too, right?
Yeah.
Only because beta blocker is contraindicated.
Yeah, exactly. Yeah. Now the next day we advance it to the next day. I don't know why this is not allowed. Anyway,
Because
we advance
you're
it.
on the
Huh?
2-minute screen.
Let me see what time is it now.
So give her like
Coumadin. We give her next day. We give her Coumadin and daily PTINR. Oh, I think I should write a warfarin.
can you counsel her?
Yeah, I'm gonna cancel. We got 1 minute. Okay. And let's do PTINR. Ouch. We do it every day. So what else do you want to do?
Counsel her.
What do you want to cancel on?
Counsel her on just counsel, whatever. mammography, colonoscopy, influenza vaccine.
Yeah, mama.
I'll probably give her pneumococcal vaccine because if she is COPD.
PP, yeah, PPSV 23. By the way, I should have booked it later, but it's because I don't have time now. Oh, it's gonna block. It's gonna. Yeah, you do it later, like not right now. You just do it later.
Mm-hmm.
I rushed it just because of the times. Okay, yeah. So now I'm gonna show you how the case can present different ways. So what are the principal three things that you need in management of atrial fibrillation?
You need to rate control with beta blockers. If that is contraindicated, then use calcium channel blockers. Then you have to do rhythm control. It depends. If they are unstable, then you cardiovert. If they are stable, then you give or something.
So there are three things: rhythm control or rate control, anticoagulation to prevent systemic embolization.
Right.
Second thing. Third thing, correct underlying cause. Okay,
Mm.
that's the thing. So for this patient, for someone, when do you do cardioversion?
If they are unstable,
Yeah, excellent.
and yeah, right, that's the only reason.
Yeah, or there is severe heart failure or acute coronary syndrome, you can also do that.
Mm-hmm.
So how about, so this patient reverse, so what are the drugs used for rhythm control?
Beta blocker, calcium channel blocker.
So rhythm, those for rate control, not rhythm. Rhythm control is amiodarone, dofetilide, opitolide. Amiodarone is specifically for people who have left ventricular dysfunction.
Oh.
Okay.
Mm-hmm.
So without chronic antiarrhythmic therapy, only 20 to 30% of patients who are successfully cardioverted remain for more than 1 year. So this one, that only if someone who has heart failure, you give him amiodarone. But if someone without heart failure, you can give him dafetalide or epitolide or other stuff. Okay, so the two commonly used medications for maintenance therapy are amiodarone and sotalol. Sotalol, if someone what medical condition you give sotalol? So heart failure, left ventricular dysfunction, you give amiodarone.
Mm-hmm.
How about sotalol? What medical condition do you give? If there's a coronary artery disease.
Okay.
Okay, that's it. Okay, so what are the three important drugs for rate control now?
Beta blocker, calcium channel blocker,
And digoxin.
digoxin.
Okay, when do you give digoxin?
When the other two are contraindicated,
Yeah, and when there's hypotension and heart failure.
hypotension and heart failure.
Yeah, okay. When do you give beta blocker? Yeah, in heart failure, you know why? Because digoxin increases contractility. It's a wonderful mechanism. Like,
Yeah.
slow the heart rate and increases contractility. It works on the ATPs and stuff. It's very interesting. So when do you give beta blocker?
Um. When?
For someone who have history of angina,
Mm-hmm.
okay, or acute MI. When do you give calcium channel blocker?
When beta blocker is contraindicated.
Yeah, and chronic lung disease. Yeah.
Okay.
Okay. How about if someone did not respond to beta blocker or calcium channel blocker? What do you do? Sometimes even in the software they showed you this patient did not respond. What do you do?
Oh, is that when you cardio work?
Yeah, radio frequency ablation.
What's that?
AV nodal ablation. They ablate the AV node.
Okay.
So which one more preferred, rhythm control or rate control?
Which one is more?
Yeah. How do
What's
you
the
choose?
question?
How do you choose between rate or rhythm control?
You always control the rate first, and then the rhythm.
Yeah. So they always thought they control rhythm before rate. Okay. So
So
that's
it's
why.
not first.
Hmm?
It's not rate control first.
No, no, it is the rate control first. Like
Oh.
initially, before they thought you controlled rhythm first and then the rate. But now, no. First you control the rate, and then if it didn't work, then you do the rhythm. Okay, and both, regardless, you gotta put them on anticoagulation.
Hmm.
So now, what is the difference? Because you know this management of AFib is very important, high yield. So
Hmm.
when do you consider anticoagulation?
Um. Consider anticoagulation if they have risk factors, and
So if
if they have it more, if they have if they have it less than 48 hours.
excellent, yeah, and if they have chronic AF or recurrent AF or prior or after cardioversion, then you do these things. You control. You gotta put anticoagulation, or you know the Chad VASC score.
Yes.
If it's more than 2, then you can give them anticoagulation.
Mm-hmm.
Okay, and I think this girl, she has 100 or something in these travel score, everything. So
Yeah.
you gotta give her everything. How about if the patient
Because
have?
the thing is, if they are less than 48 hours, you have to anticoagulate because you don't want them to get a stroke.
Exactly, yeah, you're
But,
right.
but if it's more than 48 hours, it's too late for that anyway.
Exactly, yeah.
So at that point, what would you do? If it's more than 48 hours, you cardio it? No,
According
don't.
to Chad VASC.
Okay.
Yeah. So how about if patient of less than 48 hours without
Hmm.
current valvular disease or left ventricular dysfunction? What do you do?
Sorry, what's. Mm,
Like someone who have less than 48-hour atrial fibrillation and no risk factors for anticoagulation. What do you do? You give them just heparin and without Coumadin.
oh, okay.
Okay, so that's the thing. So when should I admit the patient with atrial fibrillation?
Mm,
Mhm.
you can admit them once they are stable from the AFib.
No, like I mean, admit them to the hospital.
Yeah.
Hmm? So if someone doesn't have any risk factors and he present with atrial fibrillation, do you admit him to the inpatient?
Oh no.
Yeah, just in the emergency room.
Hmm.
You don't need to admit him. On hospitalization, only in high-risk hemodynamic and stable patient.
Yeah.
That's the thing. Now, how do you search for underlying cause for atrial fibrillation?
You gotta do an echo and see if there is any mitral stenosis or enlargement of left atrium.
Okay, yeah, and the TSH, this is very important. So if someone have normal free T4 and low TSH, what is that?
Subclinical.
Yeah, excellent. This is subclinical hyperthyroidism.
Mm-hmm.
So we gotta treat that before you, so you don't cardiovert them. You treat that before you cardiovert them.
Mm-hmm.
Okay, if that respond, because sometimes it could be that could be the reason.
Right.
Yeah. So that's about atrial fibrillation. Okay.
Mm-hmm.
So let's do another case then. Okay. So now this one is a 61-year-old man involved in a motor vehicle accident, came to the emergency room. He has chest pain after motor vehicle accident. Blood pressure is 80/40. Pulse rate is 130. Respiratory rate is 30. Okay. Now he's in the emergency room. History, all what you can. He complained of severe chest pain, 10 out of 10. Non-radiating, shortness of breath. Chest wall impacted the steering wheel.
Mm-hmm.
No other history available. That's it. That's a very interesting case. I like it. This is your
Oh,
specialty. You
he
like
has
emergency
he
room,
has
huh?
he has aortic rupture.
Yeah, let's see what we can do right now. Okay. So what do you want to do right now?
Well, first I want to stabilize him. Stabilizing orders, IV access, fluids, pulse ox, oxygen. Um, get you know get like a chest X-ray or CT or something. I don't know. Cardiac monitor, EKG. Yep.
What else? Under finger, stick glucose. What else?
Finger stick glucose. Okay.
IV fluid.
Give him saline.
Hmm?
Normal saline.
Yeah. Let's do elevate the patient legs.
Sure. Yeah. Oh, we have to do fast. No.
Yeah.
Any motor vehicle accident, blunt trauma. Do you do fast or no?
Yeah, we gotta do that too. Right, yeah. No, that's a good idea. Let's get the chest X-ray. Let's do quick physical. Just heart, lung, general. No,
Mm-hmm.
yeah, that's it. Okay. Lung is clear bilaterally, and there's 15 cm JVT. Boom! We got our diagnosis, right? S2 is muffled. Pulse ox is 88. Okay, so we gotta do something urgent. What it is? What it is?
We have to do cardiocentesis,
Excellent. Yeah,
pericardiocentesis.
pericardiocentesis. Okay, let's just continue. Let's advance for the pericardiocentesis. And let's consult this cardiovascular surgeon too. So blood pressure started improving with your management. Patient is thankful right now. So now every time we did not have history, so now let's just see how he's doing. Just to say hi, we get more history. Okay. We got more history now. Now let's just order transesophageal echo. T.
You can just do a regular echo. Why you want to do TEE?
Yeah, you're right. Yeah, thoracic echo. Right. TTE. Sorry.
Right.
Okay, let's get the result of the EKG.
So basically, he had a Beck's triad.
Yeah, exactly. Yeah. So he has sinus tachycardia, low voltage QRS, electrical alternate. Chest X-ray shows a globular heart with air fluid level in the pericardial cavity. The echo shows review fluid in the pericardial cavity, tamponade. Okay. So now you get the consult. The consult of cardiovascular says no operation. So what do you do right now? Shift him to the ICU, right?
Yeah, I think so.
Yeah, we did the emergency management. That's cool. Like when you're an ER doctor, you just do your thing and let's send them to the ICU. They will take care of it. Yeah, you don't have to do it. Okay, so now shift him to the ICU. What do you want to do in the ICU?
We want to make sure that we are
Vitals, huh?
checking his PTT, PT,
Yeah, the panic, omeprazole,
activity,
bed rest. What else? Panic, NPO, panic.
input output,
Input output, yeah.
and cardiac monitor.
Yeah, card monitor, yeah, right. Let's put Swan Gans catheter. Let's put in Foley catheter. What else? Let's do compression. Let's put CBC. CMP, we didn't order that. PT, PTT, what else? He's on IV fluid, right? Yeah. Let's put him type if he needs blood. Give him something for the pain. We forgot the Tylenol. Okay, what else? Do you want to order anything else?
No, I think we're good, no?
Okay, let's see. Looks good on here. No, let's get the results. It's just. Wow, so his hemoglobin is 7. What do you want to do right now?
Oh my god, I'm gonna transfuse him. So do type in screen, PT, PTT, INR.
Yeah, I did all of that, yeah.
Cross match, and then give him packed RBCs.
Yeah, packed.
You did type in cross match?
Yeah, I did all of them, yeah.
Oh. One of my friends, she took the exam.
Yeah.
She said that on day 2, she left 2 hours earlier because of her cases were ending so early that she ended up finishing the test 2 hours early too.
Yeah, yeah,
Check.
after
I want to
transfusions.
check her.
Mm.
I want to check her H&H in like one day.
Goodness. That's a good thought, yeah. Let's repeat TTE, see how she's doing. We do chest x-ray again. Let's discontinue the Foley catheter. What is it?
Mm-hmm.
What is the Foley catheter? Okay, yeah. So that's about it. If you do this much, I think you're good to go. That's for this.
Right.
Yeah. Now, do you want to cancel anything? Like he's 61 years old.
Yeah, let's cancel her. Let's do a memo on her. Let's do colonoscopy. Give her vaccine.
Mama, colonoscopy.
Oh, is it a? Oh, sorry, it was a male. You told me it was a male patient, so
Yeah,
no
yeah, it
memo.
was a male, yeah.
No memo.
Yeah, but that's okay, you know. You know, the first breast surgery that I attended was on male. Breast cancer
Oh,
surgery.
really?
Yeah,
What?
I said
That's so weird.
interesting. Yeah,
He must have had a BRCA gene.
yeah, exactly. Yeah.
Mm.
What vaccine do you want to give?
Under 65. So just influenza.
Drive with seatbelt. Need that.
Or for sure, because it was an MBA case.
Yeah, that's the most important
Safe sex. No, I'm just kidding.
one. Yeah, why not? You know.
I don't think a 61-year-old would be fooling around.
Really? No, there are some. It was,
Mm.
funny. Last time I saw a video, like there was this girl. She's 20 years old with a guy who's
Mm-hmm.
60 years old. Like it's crazy.
Oh my God.
Yeah, it's very interesting. How do you summarize this case?
So we had a guy with a motor vehicle accident, and on exam he has a classic case of Beck's triad, which is cardiac tamponade. We know tamponade we have to do. We can see it on an X-ray with a big heart, or we could see it on echo as well. But mostly it's a physical diagnosis, and we have to do pericardiocentesis to relieve the pressure from the chest wall from the heart. So once we do that, we monitor the patient and we kind of, manage them. And I think that's all I could say.
Yeah, so this when you have Beck triad, which is hypertension, extended neck vein, and muffled heart sound. That's a
Mhm.
tamponade. And whenever you have someone who's after motor vehicle accident with hypertension doesn't respond to the fluid, most likely tamponade. Other DDX, like right ventricular contusion, superior vena cava obstruction, ruptured tricuspid valve, tension pneumothorax, pulmonary embolism, cardiogenic shock, that's all other differentials.
Mhm.
So the life-saving step here, emergency pericardiocentesis. Okay. What
Yes.
if patient does not respond to pericardiocentesis and still deteriorating? What do you do?
Oh, Oh, hmm, not sure.
You do emergent thoracotomy.
Um, Emergent
Yeah, thoracotomy, you just said.
part of me.
Yeah,
That means you make a hole in their chest.
yeah, you just cut their chest open and fix what's going on. Okay,
Wow.
yeah, it's intense. Do you want to be a cardiovascular surgeon?
No,
Yeah, no, yeah, I'm good,
I don't
yeah.
want to be. I don't want to be a surgeon.
Yeah, I'm good. I don't want to. Yeah. Right.
I need family time. I have a family,
That's
so I'm going.
true. Yeah. So yeah, you do, and then you check the fluid. You take the pericardial fluid for the cell count.
Mm-hmm.
You check it periodically every 24 hours. If there's any bacterial infection or anything like that, you treat it accordingly. What if the YBC raised significantly?
The what race?
The white blood cell?
Uh-huh.
Yeah.
Oh, then we give them antibiotics, right?
Yeah, you give them and remove the catheter. So why do we give Swan-Ganz catheter?
Oh, because you want to check the pressure in the heart to make sure that the PCWP goes down. That will tell you that the patient is not going to have cardiogenic shock from
Exactly, and
chest.
there's not reaccumulation of pericardial fluid.
Right. It's a way to measure that, okay, your heart is doing better.
Exactly, yeah. And when do you have to repeat echo and chest X-ray in this patient?
After pericardiocentesis is done to make sure the fluid is out.
Yeah, in a 24-hour, you get it next day with the
Yeah.
24 hour. You read them. Yeah, that's about it. So that's just to summarize the cases that we did for today. That we did this case, which is when you have someone presented with a motor vehicle accident, big triad, you do the police BS and then pericardiocentesis, and then you admit him to the ICU, you start V panic, and you repeat the chest X-ray and
Correct.
TTE. Okay, that's the thing. When you have atrial fibrillation present to the office, send him to the ER. You start the police BS, and then you give him cardiazem, and you do the glim,
Mm-hmm.
cataglym. Okay, that's the thing. And then you order the cardiazem, heparin, PTT every 6 hours. Okay, and then you admit her like for this patient to have a problem and put him on V panic.
Mm-hmm.
Okay, and then you do CBC daily and then a heparin and cardiazem. And then at the end, once stabilized, once discharge him, discontinue IV cardiazem to PO cardiazem
Mm-hmm.
and give him Coumadin next day, bridge with warfarin. And that's
Yeah.
about it for. If you look
Mm.
at many of the stuff repetitive, the same thing that we do it, it's just slight differences. Like police BS, V panic, cataglin. This is can be with every case.
Every case. Yeah.
Yeah,
You just, and what changes is the actual life-saving treatments, managements you do,
that's true. Yeah,
such as antibiotics, procedures such as pericardiocentesis, or cholecystectomies, or appendectomy, like things like that, right?
yeah, you're right. Yeah, that's true. Right. Yeah. So that's the difference. So for someone with the first case that we had, you remember what it was? It was endocarditis.
Endocarditis.
Excellent. Yeah.
Endocarditis.
So yeah, so you present to the emergency. You start him with police BS, okay, police bullshit, and then you give him the antibiotics,
Mm-hmm.
vancomycin, gentamicin, and you treat him symptomatically. If you look at it, it's not that hard. Like these CCS, it's fun.
It's fun,
Yeah,
yeah.
these mnemonics also make it fun. And then when you
Yeah.
admit him, put him V panic and order TEE, CBC, hepatitis C, HIV. You do that for IV drug abuser.
Uh-huh.
And then you wait for the culture result. Once you have it methicillin sensitive, switch it to nafcillin, and that's it. You're good to go.
Yeah.
Counsel him, man, don't alcohol, no smoking, no drugs, no. And that's it. He will be fine. Good to go. Yeah, so now, I'm happy that we finished. I think we finished like almost 15. Let's left with 25. Wow, that's amazing. Yeah.
Okay.
Good. So I'll see you then tomorrow.
Yes.